Hello guys, how's it going? This is Santos again with another assessment. We're going to be doing the abdomen again. This is going to be for nursing 3403. And we're going to be doing the abdomen. We're going to be doing the history, the IPPA, and except for the abdomen, we're going to be doing the inspection, auscultation, percussion, and palpation. That's going to be the difference from the other assessments that I mentioned in my other video before. So pretty much to start off, I have my brother again to help me out. And I guess let's get started on the assessment. First of all, you're going to have your patient, of course, you're going to have your patient in front of you, you're going to be in the room. You're going to get your history, what kind of diet has this patient had, when was the last time they pooped. It's pretty much the same thing what we've done before with the other video. What is their diet? When was the last time that they pooped? How often do they usually poop? I've met some patients that sometimes they poop, once every 3 days, and other patients that poop 3 times a day. So that's just one of the things when you're trying to assess and then trying to figure out what's going on with your patient. That'll clue you into what's going on with their digestive system. Are they taking any medications to help them go to the restroom? Are they taking any medications, pain medications that might slow down the intestinal movement? So you also want to get the history. Okay, a lot of the times you'll get patients that come from a nursing home, and they have a PEG tube, and then sure enough, in an assessment or during the report, they didn't tell you that the patient had an OG tube or doesn't have a PEG tube, or not only has a PEG tube but might have a different kind of PEG tube, a smaller PEG tube, or it's positioned differently, or the bumper is at a different place, or it's coming out, or the stitches aren't there, so. These are part of the history and part of the communication between nurses that you got to do. And a lot of the times if it goes uncommunicated between 2 people, you have to find out yourself, and you have to document that and then pass that on. And that's, of course, that's not just to cover your ass, but of course that's to, for the patient's sake. That way, the information can be transferred over. So, continuing on with the abdomen assessment, we're going to start off with the inspection. Excuse me. So with inspection, of course, you're going to have either, a lot of the times my patients are going to be intubated. So, I could just cover them up and, pick up the gown. But in different floors, such as, the med surg or tele floor or step down or whatever step down unit you might be in, you got to take, your presence into consideration. Sometimes, some female patients might not be okay with a male nurse, you lifting up their shirt all the way up or their gown. So keep that in mind. So of course, with inspection, you're going to assess the skin. Are there any abrasions, any lesions? Is there any swelling, any redness? And as a patient is laying down, you want to see, are they breathing okay? Sometimes you can even see the heart rate from the abdomen of the descending aorta there. And continuing on with the inspection, if the patient has a PEG tube, is there redness, is there any drainage, what's going on exactly, and that'll clue you into what's going on with the patient. And like I said, a lot of times you won't be aware that the patient has a PEG tube coming in from a nursing home, and you end up doing your own assessment, and sure enough, that's what they have. I'm going to move on to percussion just because that's the way I follow it. But typically you do the inspection, auscultation, percussion, and then palpation at the end with the abdomen assessment. But moving on to percussion, you want to do, go ahead and stand up. With the percussion, of course, you want to use your 2 fingers and you want to tap on the abdomen. Typically, you don't want to miss a quadrant. I mean, if you go on from the right upper quadrant and you're moving on to your left upper quadrant, if you have a patient with liver problems or you don't know that the patient has liver problems, but as percussion, you find something off on this quadrant and the lower quadrant more than what you're supposed to find on this quadrant, of course you're gonna know that something's off with the patient's liver. Sometimes you'll see that distension. Sometimes you'll see tender to the touch, or even before you percuss, you're gonna hear that difference, and you're gonna feel the difference. So you want to go down to the lower quadrants. You want to assess the whole stomach, and one. I mean, a lot of times they'll tell you to start off in the lower quadrant and work your way around, but really, as long as it gets done, in my opinion, that's what counts. You could go ahead, Sam. So, as I mentioned before, you want to assess what should be in that quadrant. I mean, yeah, like I said, on the right upper quadrant, you're going to have the liver. On the left upper quadrant, you're going to have the spleen. Can you feel the spleen? Does it sound different? Is there inflammation? And then we'll go into that section in a little bit. Um, and All right, so continue on with the percussion. If you're going to be percussing in one quadrant, and you notice that the vowels just don't sound the same in these quadrants, then what's the history? What's this patient coming in for? Sure enough, they might have an ischemic bowel, or they're just really backed up. They haven't had a bowel movement in 3 days, when usually they have a bowel movement every day or two every day. So part of the history will go into your assessment. Moving on to the palpation, same thing. You're gonna assess your all your quadrants. Start off from the top, or start off from whatever quadrant you're comfortable with. Work your way around and end up in the same quadrant. Now, you want to assess: is the stomach hard? Is it distended? Is it soft? Is there pain? Because like I mentioned before, a lot of the times, like, the patient will come in and they'll just say that they have stomach pain, but sure enough, upon palpation and upon inspection, you're going to see the abdomen distended, and they haven't had a bowel movement in so long. Or you have a patient from a nursing home, you end up finding out that they have a peg tube, and their abdomen is distended, it's hard, they haven't had a bowel movement, and they have residuals of like 600 or something like that, but they've just kept on pushing on, the feedings. And you'll have some of these doctors that'll come in and be like, no, you don't have to stop the feedings, so and so journals say that you don't have to stop the feedings, blah blah blah. But would you rather go based off of your pride and your knowledge, and say that you don't have to stop the feelings just because this journal says so, or just because a doctor says so, or just based off of your experience? Or do you want to play it safe for the patient's sake, and do what's right and pause the feedings, and assess what else is going on? Give the patient an enema, or some kind of lactulose or a stool softener, just to get everything out. So yeah, you'll hear that with some doctors that come from up north, and they'll tell you, no, you don't have to stop the feedings. Go based off of your instinct. I'm pretty sure that some of your professors will tell you the same thing, is that you have that sixth sense as a nurse. You have a feeling with what's going on with a patient. Go ahead and go with it. Just take that extra step just to be safe. Excuse me. And with the palpation again, sometimes a patient comes in with right lower quadrant pain. What are you going to suspect? You're going to suspect appendicitis. So are you going to palpate? Are you going to percuss? It's not advised, but at the same time, it doesn't take much to suspect that. I mean, if the patient comes in hunched over, has pain, has trouble walking, if you have them jump, or if you have them kind of like cough a little bit, or you do some of those assessments to assess if it's the appendix or not. I mean, you're not going to be putting any pressure on that lower quadrant. You're going to risk that a possible rupture, and then you're going to have the patient come in, you do your assessment, palpate when you're not supposed to, and then you're going to be going straight to OR. So that's the last thing that you want to do, is have the patient get septic as a result of your palpation. I know some of the professors will say, well, it's part of your assessment. Yeah, but at the same time, you have common sense, and you don't want to hurt the patient either. It's like a patient that has a broken leg, you're not going to do range of motion on that leg either. Common sense. Auscultating, same thing with the auscultation. You have your patient either laying down or standing up, but preferably laying down. You're going to do all the quadrants. You can start off in upper, lower, whatever. Again, a lot of the times I get these patients that have, the peg tube, they have the OG tube because they're intubated. You want to auscultate all the quadrants, starting from the, you can start off on the upper right quadrant and work your way around. So, what are you assessing for? You're trying to listen for the bowel movements. Are they hyperactive? Are they hypoactive? Has the patient gotten any feedings? Have they not gotten any feedings? What's the reason why they have? When did they start the feedings? What was the reason? that they did start the feedings. Is the patient okay to eat now? Do they even have any bowel movements? All these are the questions that you have to ask yourself when you're doing these assessments, especially when you're auscultating, because when a patient comes in from, post-op from an ischemic bowel, you've never had this patient before, and they tell you to do trough feedings, which is just 20 mLs, 20 or 30 mLs, and feeding either via PEG tube or OG tube, typically OG tube. You're going to have this patient, come in from OR, they give you these orders, and yeah, sure, you can start them, but then, 3 hours from now, what are your residuals? Or, the next day, what's your residuals? So you want to assess that, are the intestines, are they moving, or is that peristalsis going? So all of that will, based off of your history, you want to know what's going on, and then try to get that going for the next day as well. So yeah, continuing on with the auscultation. A lot of the times what I see in my unit, pretty much it'll be, the patient will be intubated. They don't have they don't have any bowel movements for like a certain amount of days, but at the same time, have they eaten anything? And of course that goes on to your history, what's going on. And what I would recommend is, keep track, pretty much all the hospitals will have that, but I mean, you want to keep track of where the patient came from. Is it in a nursing home? What they did over there? Because a lot of times when you get these transfers, they won't tell you what's going on. All right. And one of the things that they mentioned in the PowerPoints from class was checking your kidneys, which would be either the percussion, the percussion, where you have the patient stand up or you have them turn to the side and then you bang the back. I mean, a lot of the times, I mean, that's what's kind of funny about these assessments is that, you're going to be doing this, or you already know that the patient's a renal patient, they're getting dialysis. Are you really going to be, trying to force an intubated patient on the back, hit their back when you know that either they have hydronephrosis, they already have pain? At the same time, you want to use your common sense. You have your lab values or your renal panel there. Like, if you have your lab values and you have your renal panel, or you have your ultrasound that they did before, do you really want to go to, do you really want to put yourself and put the patient, uncomfortably and hit them in the back? I mean, you're probably just going to cause them more pain. But at the same time, if you have a patient, doesn't really know what's going on, you won't need to percuss, is there swelling in the back? So you got to implement your assessment based off of what's going on at that time, based off of what the patient needs. And a lot of these new nurses will be like, oh no, well, I got to do this assessment. No, I mean, a lot of the times I would say it's 90% it's like a focus assessment, and then the rest of it is just integrated of what's going on around the patient. For example, if the patient comes in, post-ischemic bowel surgery, they do the resection. Are you going to be worried about the kidneys? Yeah, you are going to be worried about the kidneys, but it's not going to be the first thing they're going to be looking at. You're going to be looking, at the incision side. You're going to be, is there other bowel movements? Little things like that is what you'll pick up as you go throughout your nursing career. Pretty much that covers the abdomen. I mean, it's not a big system to go super thorough with. I mean, there's not too much to do. I mean, it's pretty much like any other system. You do your history, your inspection, auscultation, percussion, and palpation. Like I said, depending on what floor you're in, you're gonna have your patient, be positioned a different way. You're gonna be focused on different things. But if I missed anything, go ahead and feel free to comment, or if you have any questions, go ahead and comment as well. I'll get back to you guys. Thank you.